Yeah, Andrea, we can start now. Yeah, please take it forward. Andrea, can you hear me?
Yes, sure. We are going to start. Okay, I just was doing to record the webinar, but like we're already with YouTube.
Okay, over to you.
Okay, that's perfect. So we have everything settled. So let's start our webinar. So good morning, good afternoon to everyone, depending where you are, and welcome to today's webinar, Data Management Essential for Health Professional. My name is Andrea Rios. I work in UNITAR for the Division of People and Social Inclusion, and I will be your host for this session. We are thrilled to be partnering with Empower School of Health to bring you this important and timely topic. We are honored to have two esteemed speakers with us today, Mr. Berry Chovit and Dr. Maran Gopal, both renowned experts in this file. This is going to be the agenda of this meeting. First, we're going to have the introduction and the speech of Dr. Maran, and after will be Mr. Berry. I will do, if you don't mind, do poll just to know all your feedback and point of views. So let me just to present our first speaker. Dr. Kimeran Gopal is an experienced health professional with over 30 years of expertise in health system reforms and strengthening in India, holding an MBBS and MD in preventive and social medicine. He has a proven record of accomplishment of leadership and successful management of partnerships models in multi-partner and cross-sector projects. During his tenure as senior consultant in health at the National Institute for Transforming India, Dr. Madan provides essential support for various health sector reforms and policy levels initiatives. Currently serving as Advisor Public Administration at the National Health System Resources Center, Dr. Gopal continued to contribute his expertise to further enhance public health administration in India. So, Mr. Gopal, thank you very much for being here, and just we are thrilled to listen your speech. The floor is yours.
Okay, thank you. Good morning, good afternoon, good evening, and thanks Empower and UNITAR for giving this opportunity to share my views and thoughts. I would be sharing what we have been doing. I would be talking more from the practice point of view. That means at the policy level, how we look at the data, how we manage the data, and how we use the data for arriving at policy and policy level decisions. So may I given the permission to share my screen? Okay, thanks. So this is my screen visible? Can anybody confirm?
Yes, sir.
Yes,
okay.
your screen is visible.
Okay. Is it in the full screen now? Okay, that's
Yes,
fine.
sir.
If it is not moving, then let me know. Okay. So I would be just talking about okay, how the economic evaluations of national programs and how they are viable. So I would be just sharing few of the things which we do uh, at the national level. We see that if you look at the way things happen, uh, for any programs, we have to do an economic evaluation because economic evaluation is essential for ensuring efficient and effective use of public funds. In India, we are having many systems, many data collection systems, which I would be dwelling when we subsequently talk in the relevant slides. But you see that how it is important that we should be carrying out economic evaluation of the with the use of data and the data elements. Because we have been estimating that around 237 billion US dollars are lost annually due to healthcare inefficiencies. These healthcare inefficiencies are because of poor monitoring and poor data insights, which could have resulted in saying of this amount of money. Apart from that, we can identify programs most likely to improve health outcomes at a reasonable cost. These are the important caveats, I think, when we are talking about any data or data related things. We should see that what is the cost benefit of a particular interventions or a particular program is going to bring, and what is the cost benefit of that thing to the people. So we usually see from that point of view, any data we see how much benefit it is giving and how much it has been cost effective for us. So if you look at the way the system, how we are using the system, we are using the system so that effective monitoring of the programs happen and a better implementation can happen. We all appreciate that monitoring is essential for ensuring efficient and effective program implementation. This is the fundamental fact. But on the contrary, if you see that only 38% of the government programs in India are effectively monitored, that shows that there is a lot of scope to improve our monitoring as well as bringing efficiencies into the monitoring as well as the implementation processes. So what does it includes in the effective monitoring practices? That entails regular data collection and analysis, use of technology and stakeholder engagement. If you talk about the programs, in India, we have made a lot of, in India, we are talking about numbers. We have to deal with 1.4 billion population. We are having more than 200,000 health facilities. That's in the public sector. If you talk about the counties, we are having around 750 county level health institutions. If you talk about medical colleges, we have more than 750 medical colleges in the country. Look at the number. But to monitor that thing, we require regular data collection and systemic mechanisms. We do have a system in place, which I will dwell in my subsequent things. Besides that, for dealing with these numbers, we require the use of technology. Manual interventions usually take time. Had it been a manual intervention during the COVID times, it would have been a very difficult time for us to get information from each and every villages. The smallest unit is village. We are having around 1 million of villages in the country. And getting information from all these things, the use of technology is very much warranted. Otherwise, it would be very difficult to get a timely information from that. Besides that, there are many stakeholders who are involved. We do have a battery of 1 million ASHA volunteers or the health volunteers who are at each and every village, plus around 2 lakh, around 3 lakh your health workers manning at the sub center for the Ayushman Arogya Mandirs. Then we are having the around 30,000 public primary health institutions providing that. So you see that unless I engage with all these stakeholders, I won't be getting an effective data which can be used for monitoring this. I'm just giving numbers, not to scare, but to see the magnitude of the things which we are handling at the country level. But the silver lining is we are trying to strengthen the monitoring system and so that we improve the performance of our national programs as well as to increase the better outcomes. Interestingly, if you have seen the trends of IMR and MMR, they're already on the declining side. And if you look at the how we are systematically evaluating the economics, I am just focusing on economics so that you can appreciate how from the data elements you can move up to the economic evaluation so that it acts as an essential tool for ensuring that national programs in India are cost effective and achieve the desired outcomes. These are the main types of economic evaluation which are doing. We do a cost effective analysis, we do a cost utility analysis, and we do cost benefit analysis and budget impact analysis. Every year we earmark around 100,000 Indian rupees, crore Indian rupees for the health. Unless and until I know that what is the cost effectiveness of this budgetary allocation, how it has been utilized by the people, what benefit it is providing, and what impact it is creating. That thing I have to evaluate. So that's why we have been doing economic evaluations, and every year before the budget is presented, usually the economic survey is tabled in the parliament so that it shows that how our budget and the efforts stand vis-a-vis the cost-effective analysis, utility analysis, benefit analysis. These evaluation provide us valuable insights into the program cost effectiveness and help us in arriving at an informed decision so that we are able to allocate the resources and tweak in the program design if it is required. Then if you look at the how the system has evolved, national evaluation system, how has it has evolved. Initially, it was an input-based monitoring, input-based system. That means what you are giving. Now we have moved to outcome-oriented evaluations. So one of the important things which currently is the outcome monitoring framework with the National Institute for Transforming India, which is having for all the departments in the at the Government of India level. Basically, it is focusing on the outcome-oriented evaluation, how the things are moving. These are the key milestones which the country has achieved. We have set up, we started with a program evaluation office, then the independent evaluation office. Now it is known as Development Monitoring and Evaluation Office, which is stationed at Niti Aayog, which is the apex policy think tank directly under the highest office of the country. So why this kind of evaluation? Because if we are having a better evaluation process, it can inform the policy decisions and other things so that we can bring in efficiencies into the policy program implementation and the outcome which are envisaged through program objectives, they have been achieved. Then if you look at the case, I will just cite some case studies from the evaluation side, case studies, what we have been doing. We see that National Immunization Program is one of the largest immunization program across the globe. And it has been a very cost-effective investment in child's health. So you see that we are providing around 12 antigens free of cost to all the children of the country. And see the reduction in the vaccine preventable disease in the country. That's the biggest effectiveness of this investment which we can see. Beside that,
okay. Dr. Madan, are you there?
Yes. Yes. Are you able to see my slides?
Yeah, it was the internet, I guess. So if you can just repeat the final phrases of the final topic that you were talking about, because we missed a little bit just because of the internet connection. Thank you.
So what I'm saying, I'm not able to follow.
No, just the last thing that you said, please.
Please come again.
We had a problem with the connection, so you were frozen. So that's why if you just can start again, just like the same as you were saying.
I have to say
To
start
not miss
from
anything.
which slide.
So
No.
You can just little bit. If you can repeat again, if you can just go backwards just for 2 minutes, and if you can just because your internet was frozen.
Is it fine now?
Yes, now it's perfect.
So can I start?
Yes.
Okay, that's fine. Perfect. Okay. So you see that how the national systems have evolved. I have told about the key milestones which the country has achieved. Now we are having a development monitoring and evaluation office, which is located at the Niti Aayog, which is the apex policy think tank for Government of India. I will now tell you about some of the case studies, how the evaluations have shown the effectiveness of the national programs which we handle. National Immunization Program, which is the largest, one of the largest public health programs in the world, it has shown that how the vaccines which have been provided free of cost for preventing different vaccine preventable disease, how it has been a cost-effective investment in child health in the country. It has shown that the economic evaluation found that it is highly cost-effective with a cost-benefit ratio of 16:1. And it has prevented millions of deaths and illness and saved India billions of dollars in healthcare costs. A critical investment in health and well-being of the Indian children. I'm not talking about the basics, principles, and other things. I'm just saying that what are the use cases of use of the data, how the data can be used for evaluation, how we can go to the next step and carry out an economic evaluation, find out how the data speak to us so that whole of the world is now talking about data-driven governance. And you see, these are the few of the examples how the data can feed into the policies and how it can improve in our monitoring and implementation processes. So other use cases, your centralized evaluation bodies. At India, we are having this centralized evaluation, that is, which I already mentioned. Apart from that, Department of Expenditure is also other centralized body, which is assisted by Economic Advisory Council. And every year, before the budget, they usually put in the economic survey of the country, which is tabled on the parliament, and it sees that how what the programs are doing, how vital is is in ensuring government programs are implemented effectively and efficiently. Because government services are for the welfare state, and we have to always find out how these welfare things are working efficiently and effectively. Besides, we always carry out at the health ministry, we have this combined review missions wherein with along with the donor partners, we usually go and try to get information on the ground what has transpired after our interventions. We do have national health and family surveys as in line with the global practices. We are into the sixth round of this NFHS 6. NFHS 5 data is already there. Besides that, we carry out a lot of implementation research. We do have a research agency which is known as Indian Council of Medical Research, which is the apex research body, and carry out a lot of implementation research. So beside these evaluations, there is another mechanism which we are having in which data is fed into our system, which we call it as health management information system, HMIS. Which essentially consists of management information system. That means how the things are being managed at the ground level, how the information is processed, and how the systems are joined together to provide input, processing, output, as well as reports. This is the mechanism which exists. Apart from evaluation, this is the inbuilt process in the health system. You will appreciate that in the health system in the country, we are getting information from around 2 lakh, around 210,000 facilities across on a monthly basis. And all this information is being processed in the form of this. We are using digital mechanism for use of this. If you look at the way how this information, the regular system information which is coming, it is used for evaluating the national, this information which is coming, we are using this information for arriving at a decision so that the annual plans of the states and the infrastructure budgets are approved. Besides that, all the funds are given to the states in the form of project implementation plan. The project implementation plan is a regular feature, and this HMIS data usually gives us to monitor what are the things which were supposed to be delivered and proposed by the state, and where they stand vis-a-vis their performance. And that kind of monitoring is also there. Besides that, if working in the government, you are always challenged and always asked questions about the performance of the schemes. And this data, which is coming in the regular system, we use this data for answering the parliament questions and other things. Besides that, for the top level monitoring at the highest office, this data is also shared with them along with other ministries so that this data is also shared. And it is used, as I mentioned, that combined review missions, supported supervision, whether this data is used. Besides that, we are using this data for district hospital ranking, as well as bringing out a state index wherein we rank all the states on based on their delta performance over the years, so that the sense of competition is being created among the states, and they are being nudged to perform better and better in the coming years. And besides that, one of the important thing, because HMIS has given us information that how the mother and child services are happening. In some of the places, we do had some adverse sex ratio, and this HMIS data has been used by Ministry of Women and Child as on the Beti Bachao, Beti Padhao, that means save the girl child and teach the girl child. That campaign is already going on. It is usually contributing that too as well. These are the challenges and opportunities. We are predominantly using the data to validate the success of our program rather than for forecasting the for policy and the budgetary planning. And we have to change the challenges, data collection, standardization, resources, and institutional mechanisms. Important thing is, as I mentioned, that we have to get data from around 1 million villages. Getting data from 1 million basis, the collection is a problem. We have to monitor that which are the areas where reporting has not happened. Then standardization, because India is a land of a lot languages. Every 50 kilometers, you have a different style of the language changes, the dialect changes, everything changes. Apart from that, one of the other challenges, resources and the institutional mechanism for that. The institution, though we do have institutional mechanism, but that differ from state to state because of the federal structure. But these challenges, they have shown us a new way. The new way is we are trying to use newer technologies and trying to bring capacities beside engaging with the stakeholder. The newer technology is the Ayushman Bharat Digital Health Mission, wherein we are trying to create an ID for each and every patient, each and every person of the country. This ID would be embedded into the electronic health records, and these electronic health records would be used for patient monitoring, providing inclusion benefits to the patient, as well as doing the disease surveillance aspect. And besides that, it can contribute to the economic evaluation. Besides that, another thing which we are trying to focus is we are trying to see that this economic evaluation, which I mentioned in my earlier slide, they are conducted regularly and inform decision making more effectively, so that with a limited budget and we can have a more effective and efficient program. So future directions for this, we have to, apart from economic evaluations, we have to see that how we embrace the innovative methodologies and technology. As I mentioned in my previous slide, that we are trying to see that how the digital mission, which is currently envisaged to create around 1.4 billion electronic health records, we see that how that big number of data, how a big data analytical, because right now one of the challenges is analysis of that data. That is also one of the area where a lot of work is to be done. After this data is there, analytics is there, we have to always analyze this. You have to teach the machines so that we develop some algorithms on the trends and other things, so that machine learning and other things is also quite possible. Another future direction, we have to see that how we foster collaboration among government, private sector, and the academia, because academia bring in the rigor of the research and other things, the private sector innovations, and the government the capacity to scale and the different magnitude, scale up to a different magnitude. These collaborations become very important. Besides, we should be sharing our knowledge and best practices so that more innovations can happen, more collaborations can be affected, so and we can all evolve together. Then lastly, to improve the quality and effectiveness of any evaluation or economic evaluation in particular, inform definitely, we have to see that how the quality of these evaluations are increased. We have to see that how we do that improvisations. Then this all from my side. Thank you very much. Please unmute.
You're on mute.
Sorry. So thank you, Dr. Madam, for your insightful intervention. Your expertise and knowledge have provided us with a value perspective of your work. So we truly appreciate the time and the effort you have taken to share your experience with us. Thank you, Dr. Madam. So before to continue, we have the second speaker here, but before to continue, I will just share and launch with you the first pool. So just a few minutes to do it, please. It will be fantastic. So I leave it like this, or I don't end. Perfect. So I will leave a little bit more the pool here, but we need to continue to the second speaker. Now, without further ado, let's present the second panelist, Barry Chubis. Thank you very much. So he's a technical director of strategy and design and health system strengthening at the Chamonix International. He's a versatile healthcare administration offering more than 20 years of successful experience in supply chain management, project management, program management, and public health worldwide. Track record of managing key projects, programs, and initiatives in support of public health issues, including infectious disease, maternal and child health, and reproductive health. Proven leader, well-versed in managing cross-functional teams across multiple geographies that collaborate as a focus on it to achieve organizational goals. So, Barry, thank you very much to be here with us and to join this webinar. So the floor is yours.
Thank you. I should share my slides myself.
Up to you, how you prefer.
Fantastic. Let me just pull those up. See if I hit my button, how that's going to work. Just struggling a little bit to get there. Let me see.
If you need, I can share it. Okay, that's perfect. Thank you very much.
Okay. Here we go. All right. Yes, indeed. I am indeed Barry Chubis, and I'm on the health system strengthening team at the Global Health Supply Chain Project for the procurement and supply management at Chemonics. And I just want to thank UNITAR for holding today's webinar, and also thank Empower for inviting Chemonics to collaborate with them on the creation of the data use course, which I will touch on at the end of my presentation today. For today, I just chose a single topic here, which is I thought would be interesting, called finding the right balance in data. Move to the next slide. Yeah, I would like to kind of pose a question that I'll admit I'm not actually going to answer. I think it's just something that we all need to think about as we think about the collection of data. And the question is there a right balance in supply chain data collection? I don't think we have a direct answer to that. I think we do need to consider how much data we collect and balance that with the decisions that we need to make and the time and effort it will take for those who work in the supply chain to collect and report the data. There is a cost to report data and to collect it, even when we have an automated information data capture, or AIDC, even recognizing the fact that it can greatly reduce the overall cost. I think this seems a little bit theoretical, so I'm always about sharing an analogy. And the analogy I like to share is, I often talk about running a pizza restaurant. Assuming I do run a pizza restaurant, at the end of each day, in order to get more ingredients, in order to make pizzas the next day, we could ask some of the following questions. Do I want to know the number of kilograms of cheese, bread flour, and tomato sauce that have been used during the day? Do I also want to know how many pizzas I have sold? Do I also want to know how many of each type of each pizza I've sold based on my menu? Do I want to know how many people were served by the pizzas? Do I want to know the average group size of a group that came in to order pizzas? Do I want to know how many times I've advanced my own slides. Let me go back to the other questions. Do I want to know how many times I turned the tables, meaning how many times did the same table get used? Do I want to know the value of the average bill, or do I want to know how many desserts were ordered? And I suppose that the answer to this could be that it would be useful to know the answer to absolutely every one of those questions. But let's talk about them in a little bit more detail and talk about which ones are the ones that we're going to make the most decisions from. If we look at each of the factors here, the kilos of cheese, the number of pizzas, pizzas by type, people served, tables turned, average bill, and the number of desserts, you can see that we'll make different decisions about each of these different factors. So the first one, in my opinion, is the one that's the most important. I have to put back in however much cheese left the building, meaning if it was put on a pizza and went into an oven, that's cheese that I don't have anymore. Doesn't matter if somebody dropped the cheese on the floor, or if one of my chefs adds a little bit more cheese than some of the other chefs. If I go for number 2, which is I just count the number of pizzas, I'm making a very large assumption, and that assumption is that my chefs are following the. Sorry, I've done it again. That the chefs are following the recipe. And that's an assumption I'm not sure would be true. I think, a recipe calls for a certain value of ingredients, but we don't always use exactly the right type. It's close, but it's not exactly the same. The number of pizzas by each type of pizza helps me in managing my menu. So if I have a pizza, say, that contains artichokes, and the pizza by artichokes with artichokes on it isn't very popular, I can manage my menu or my choices by not serving pizza with artichokes. If I look at the number of people served, I can work on managing my portion sizes. So as a restaurant owner, I might make more profit by selling slightly smaller pizzas and still charging the same price and still having everyone leave happy. If I look at the number of tables turned, I can look at things like my staffing or my need to expand my restaurant. If I have a line out the door and I'm turning the tables very quickly and still have a line out the door, I may in fact need more staff or need to expand my building. If I look at the average bill, I could do some budget work, but that wouldn't really be on a daily basis. That would be on more of an annual basis. And the number of desserts I sell would literally be the icing on the cake. It's a lot of restaurants make a lot of money off of the desserts they sell. Now, if we look at the analogous set of data in pharmacies, the number of kilos of cheese is the dispensing data. So it's my opinion and that the most important data anybody could possibly collect is the dispensing data. How much did you literally put in the hands of the patients? Pharmacists like to know a little bit more about rational use, and they want to know, did the pill actually make it in the mouth of the customer? But that's not really the relevant factor here. The relevant factor is that I gave the pill to the customer, so it has left my building, so that pill has to be replaced. Whether the pill was actually consumed or not is not relevant. And in the restaurant example, that's the leftover pizza at the end of the day that they use for a takeaway box or literally gets thrown in the trash. It still winds up being a factor of something that you've used and can't retrieve. The second, third, and fourth factors, the number of pizzas by type, and the number of people served, might best be reflected in the standard treatment guidelines and also have some reflection on rational use. So, for example, are my chefs actually using the right amount of cheese per pizza? Are my chefs using the right amount of each topping? Are clinicians following the standard treatment guidelines? But of course, there can be lots of reasons why they might not do that. So, for example, we might have a standard treatment guideline that says a woman who is choosing oral contraceptives as a family planning method should only receive 3 cycles of oral contraceptives during each visit. But if I knew a woman who came in and said, well, I'm a transient farm worker and I'm going out for the season into the farming area, could I get 4 cycles? I don't see why a clinician wouldn't agree to give 4 cycles, but of course, then that might distort the data that we had if we only knew the total number of people served rather than the total number of actual items dispensed. So that dispensing data certainly remains our most important. The last items on this list are great for long-term planning, but they are particularly good for short-term planning. So hiring staff, budgeting, and selling desserts can be very important factors, but those won't really be useful to me except on a less frequent basis. The things that you make the decisions about the most frequently tend to be the most useful. Let me move on to the next slide. And I guess, obviously, I don't expect anybody to be able to read this form, especially given that tiny little writing. But this is, in fact, an A3-sized sheet that collects data for the Ministry of Health of a government. It's a paper-based form in a system that does use lots of paper. And it's the reality in many of the places in which we work. I've seen things like some countries will have as many as 50% of all lowest level health facilities may not have access to electricity. So that's the reality for a lot of folks. It's paper-based form. It's pretty impressive, and this is also a lot of data. So let's dig in a little bit on what we're looking at here. This is the this is the middle part of the form. This is for antiretrovirals. There's a list of 25 of them. And you can see if we simply count the columns here, we have 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 columns. And there are 40 products that are pre-printed on this form. So we can see that if we in fact did collect all of this data, we would be collecting 400 data points just on this one form alone, and this is just for the ARVs. There is a similar form in this country for reporting on TB medicines. There's a similar form for reporting on malaria medicines. There's a similar form on family planning products. And that's not including any of the essential medicines for which there is an entirely different format and an entirely different list. The point that I'm making is that's a lot of data to ask one individual or two individuals to collect on a regular basis, and to also expect the data to be of high quality and to be timely. Moving on to sliding a little bit more here into looking at just that first section on reporting, we can see that the amount of data we're collecting here includes the beginning stock, how much you've received from the central medical stores, how much you've dispensed, how much you've lost or adjusted, the reasons for the adjustment, the days of zero stock, the stock on hand, and the average monthly consumption. Interestingly, column H is the one I think is the most interesting because that one requires you to know how to take averages, and that information does not appear on this piece of paper. So that means that not only do you have to collect 400 pieces of information, but this piece of paper has to, first of all, most of the data in the beginning is copied from stock cards, but then the average monthly consumption has to be calculated. And that requires data for, in this particular system, is 3 months is the number you take to do the average. So this is going to require some math. And again, for all 40 products, that's quite a bit of math to expect somebody to do. Not only that, but if you do in fact have some days with zero stock, the calculation you have to make in order to adjust for the days of stock out and do the average monthly consumption can be, it's a little complicated. It's not that easy to do. If we move over just the ordering part here and we take the average monthly consumption, you now have to multiply that by 3 in order to get the maximum. You have to subtract your current stock on hand from that maximum, and then you'll figure out what your quantity to order is. Again, it's not particularly difficult, but it does require that the folks who are doing this kind of work would do this 40 times, and they would be able to have basic math and numeracy skills. Also, you also have to think that if the quantity to order winds up being a number like 973, that person also has to be able to convert 973 tablets into how many bottles it should be. Or if you work in bottles, say my average consumption is 1.333 repeating bottles. Should I order 2 bottles or should I order 1 bottle? So there's a lot of decision making that goes on here that is just beyond the basic just do math that makes such decisions not all that easy to make. In addition to all of that data, this same Ministry of Health also requires you to collect all of this information about the number of patients. So you have to collect the number of new adults, the refill adults, the new peds, the refill peds, the pre-ART adults, the pre-ART peds, and the total number of patients. And in addition to that, all of the breakdowns by all of the regimens. That information is not actually kept by the pharmacist, nor is it stored by the pharmacist. So in this case, the pharmacist has to go over to the part of the facility where this work is done and go into the DHIS2 system, which they have a version of DHIS2 there, in which they then pull out all of this patient data and have to copy all of this. And there is, again, the expectation that this data will be on time and of high quality, even though they don't actually generate or create this data. So again, we have another expectation. In addition to the 400 pieces of data and all the math, we also expect them to collect all of this patient information. Again, I'll say that this one also collects information on cotrimoxazole prophylaxis and isoniazid prophylactic therapy here as well. So just trying to make sure I got all this stuff. So to me, this, by the way, I would liken this, if you want to go back to that pizza analogy, this is likening it to the collection of pizzas by type. So, you know, all the pizzas that contain tenofovir, lamivudine, and efavirenz. And there are also some blank rows in case you need something that isn't pre-printed on the form. And this is, in fact, the most current version of the form. For those of you who know much about ARV dispensing, the most popular version of the triple fixed dose combination now is tenofovir, lamivudine, and dolutegravir, replacing efavirenz in the top line on that adult first line regimens. That one actually literally has to be written in by hand on this form. So we're adding yet another complication to our expectations. Then we've also got room at the bottom of the form for even more formulations if we needed it. And you have to fill this whole thing in, and then you have to get it approved, and then there has to be a stamp, and then that has to be divided into copies. By the way, this form is intended to be submitted by the first Friday of each month and every month, regardless of when that Friday occurs. So basically, facilities have between 1 and 6 days to fill out this form and get it submitted to the level above them. So that's quite a lot of expectation here. So let's go back to that pizza restaurant and look at this as a simple, back to making it a simple discussion again. Imagine that you go into a pizza restaurant for an evening meal, and when the waiter comes to the table and asks you for your order, the waiter also tries to assess you for your current size, your current weight. And you'll be asked by the waiter what you ate for breakfast, lunch, or what snacks you had. And you will be asked how many calories you eat in an average day. That would be somewhat bizarre. All of that would be considered unnecessary and irrelevant in a restaurant. When you say, I'll have a large pizza with mushrooms and onions, the waiter's most appropriate response is, yes, I will place that order for you right now. So what's the difference between this and getting, say, ARVs? Well, the difference here is the assumption that you are a rational customer, that you know what you need to fill your stomach, and you are making a rational decision, one that you are willing to actually pay for. In public health supply chains, however, medicines are largely free. So we collect the data in order to justify what's reasonable. How much data we collect, who collects it, and how frequently collected, however, might be worth re-examining. Some supply chains kind of accrete or just keep adding more and more required information over time, with the result that a great deal of effort is spent collecting and managing data. Everybody likes to talk about technology, so I thought it would also be worth talking about how this same idea might work in the grocery store. This might be an ideal way to collect and automate the collection of data. Many retail stores collect also one-time information about customers as part of what they call loyalty programs. So you can get a small discount on some of your products if you give them your phone number and your address. They know a lot about their purchasers. So for example, my local grocery store knows when men between 45 and 55 are buying tangerines, for example. What hour of the day is most popular for buying tangerines by that demographic, or just they can approximate when it's time to go restock those oranges, because the tangerines are all run through the scanner. This kind of system requires a significant investment in computers, networks, and barcoding, of which GS1 would be among the more valuable systems. And in the US, we're finding that self-checkout is in fact able to reduce the number of staff required to complete the tasks. But I also know an equal number of people who find it annoying to check themselves out. So what are my key points? Well, my key points are, there's a lot of information to be collected overall in most supply chains, and we really rely on the numeracy skills of pharmacy staff to do numerous calculations, even though they're relatively simple. We do, in fact, divert pharmacy staff from their core tasks, their core clinical tasks, and ask them to collect data from other folks. And there is little or no pre-service education in supply chains in pharmacy schools. The data timelines may be at the convenience of the receiver and not recognize the time needed by the sender. So in this particular case, that Friday deadline may mean that the very first day of the month, the data is due in for the entire period, and it's for the convenience of the receiver. Patient care, while valuable, might better be taken, patient data which is valuable, might better be taken from a completely separate data collection method and different frequencies as a way to reduce the duplication of effort by the same person collecting the same data. Most ordering is mathematical and isn't budget-based. It might just be easily enough that facilities might submit data and let somebody else do all that math for them. But most importantly, that if we ask people to report the data and their efforts in reporting are not met with resupply, in the quantities that they have requested, we should not anticipate that the quality or timeliness of reporting will remain the same. In fact, we should expect, if it's not timely and quality response, meaning they don't get the stuff they ask for, we should expect the quality and timeliness to go down significantly. The best reward for submitting data is getting back sufficient supply. I'm really not going to be able to answer the full question that I suppose I asked at the beginning, but I will point out that we are working on this data use course, and I want to thank Empower for inviting Chemonics to partner with them in the creation of this module, a module on data use. In that module, I talk about the principles in decision making, weighing data from different sources, using feedback loops for data use, and in decision making where there is weak or no data. And then finally, there's a bit of a session on measuring data effectiveness through the use of key performance indicators. And that's what the course has got. I also like to leave folks with some supply chain resources. There is on the website ghsupplychain.org just a ton of resources, largely focused on the project outputs from the project I've worked on, but you'll find a lot of resources there. There is a logistics handbook, which is a basic primer on supply chain there. If you as an individual are interested in joining other folks who do supply chains in public health, there's actually a group called the International Association of Public Health Logisticians, which is open up to individuals to join and participate in discussions on supply chain, and highly recommend that one, as well as the People That Deliver website. They have a theory of change around what it will take to actually professionalize the supply chain workforce, as well as the Step 2.0 leadership course at peoplethatdeliver.org. And finally, just one tool that I thought might be useful is for those who wish to assess supply chains. There's the National Supply Chain Assessment 2.0 or NSCA 2.0 toolkit available at that website. And with that, I'll say thank you and end my remarks.
So thank you very much, Mr. Barry Chovit, for your insightful presentation. It's been fascinating to hear your knowledge drawing from your extensive experience. We truly appreciate that you sharing your expertise with us. So now that we have concluded presentations, let's move on to answering some of the questions submitted by our attendees. But before of that, I will just launch the second poll. I will leave it a little bit more of time just you all to answer to it. Thank you very much. We highly appreciate to you to fill this poll. So I will launch it now. Okay, so it's done. In the meantime that all of you are answering this poll, I will go for the question to Barry. So thank you very much for reading this for us. So I have a few questions of our attendees. So the first one will be, could you please share the formula you use for the AMC?
Right. So, gosh, I wished I had a big giant whiteboard behind me to also explain it. The AMC is at its very basic is just the average monthly consumption. In theory, then, I just said earlier that we don't actually know the number of tablets literally put in the mouths of the patients. So what we often use is a proxy or substitute data for that. What we usually use is the average monthly dispensed. So that's basically a total of all of the prescriptions written during the month, or all the items that would be written in the dispensing register, which is usually a very large, I'm putting up my hands here, it's usually, again, like an A3 size sheet of paper turned on its side, landscape-wise, and you usually record the medicines that way. We tend to say that you should look at the most recent 6 months of data if possible, and use all 6 months if possible. And if there is a continuous trend always going up or always going down over the entire 6-month period, use only the most recent 3. Most systems don't actually have the ability to use 6 months worth of data. What I have learned more recently is if you don't use 6 months worth of data when calculating the AMC, you tend to get distortions in how much you think people are using, and you can be pretty far off, actually. So average monthly consumption is look at 6 months of data and usually take 6 months and do a very simple average of that dispensing information. If you didn't have that information from the lowest level of the system, you could move up 1 level or even up 2 levels and look at what they sent down. That would be called the average monthly issues data. So what I send to you and what you dispense to patients, there should be a strong correlation between those two elements of data, although I will admit it's not perfect, but it can be a reasonable substitute for what is leaving the system.
Thank you very much, Barry, for your answer. I have another question here. So during and as soon as after the disaster, the data system may collapse. At that time, what kind of data should be collected as minimum or essential data? And do you have such a defined data in a policy or a program level?
Yeah, I think that's a great question. Obviously, the world is getting used to accepting the idea that disasters or mini disasters are happening and will likely happen. Our most interesting experience as a project has been that we have in some situations set up what we call a call center. And rather than try to collect lots of data, we just basically call you up and say, how much do you have today? So if you knew what somebody's stock on hand was, or current stock on hand, you could in fact ask if it would be reasonable to assume that if I am your supplier and you have 100 today, and I know that you started with 0 and I sent you 200 previously, that if you have 100 today, that 100 must have been used. And so you can resupply on the basis only of that one piece of information. How much do you have today? I can do all that math on your behalf. Now, again, that isn't perfect. If the reason why you only have 100 is because 50 of those were destroyed in a flood and the other 50 were given to patients, I need to send you another 100, but we need to understand that the consumption rate shouldn't include the ones that were lost, the ones that were lost to the flooded part. So it isn't perfect, but it is not a terrible substitute to use just what have you got today? Tell me what you got right now as the only piece of data.
Thank you very much. So we have another one, and depending of the time, it will be the last one. So do you have any example of a country with interoperability of LMES and HMES data?
Yes, so an HMIS or a health management information usually collects information about people, and an LMIS usually collects information about stock levels. The challenge, as expressed in the rest of the question about the two data sources not aligning, actually, in my opinion, kind of makes sense. The number of people is very hard. That was the point I was trying to make about counting the number of pizzas by type. It's hard to convert people into quantities because you don't give everybody exactly the same quantity every time. Like I said, if you've got migrant folks, or you've got you're out of the tablet version of something, so you give someone an injection instead. It is hard to reconcile those two pieces of data together. What I would usually say is don't ask both systems to collect exactly the same data. Only collect the data once. When you ask people to collect the same data through exactly the same data through two different systems, you're likely to just get two different answers. Especially if two different users one is doing the HMIS and one is doing the LMIS, you're going to get two different answers, and then you can't figure out which one is right. So don't literally collect the same piece of information twice. Collect it in two different ways and see whether they correlate with one another. Don't insist on an absolute matchup.
Okay, great. Thank you very much, Barry, for sharing all your expertise, for us answer all these questions. That was great. So now that it's arrived the time to finish, as we come to the end of today's webinar, I would like to thank once again of our speakers for their valuable insight and all of your attending and engaging with us today. Thank you very much for joining Empower School of Health at UNITAR. We remind if you want to visit our website, it will be nice. If you want to find a range of courses designed for health professionals, whether you're looking to expand your knowledge in data management, public health, or other areas. So thank you again for joining us. And we hope see you again in another webinar, in another event. So thank you very much for joining today.
Thank you. Cheers. Bye-bye.
Thank you very much.